things that I do today and in the main program is I talk about the medical knowledge. I talk about some of the sociology of medicine and doctors. Of course, there's reality and there's money, and sometimes it becomes very important, and certainly too important as a component of the decision-making process. And so I'm not naive, you're not naive, and that is indeed unfortunately a part of things sometimes. So, but the knowledge that I try to share is kind of the purified knowledge, if you will. And of course, there are these externalities that impinge upon that, which need to be accounted for. But I try to give this purified kind of, this is how medicine should be in its ideal state, with reference, of course, to the realities that often impinge upon it. So somebody mentioned about getting x-rays before seeing the patient, but in reality, you always get some kind of history. I mean, person doesn't just show up at the door and says, I want an x-ray. They'll say, and you give them an x-ray, they'll say, well, I have my knee hurts, or whatever it may be, right? That's a history. I mean, it may not be a formal sit down, but there's a historical element. That's why I say history taking can be a killer app, because if you can systematize that and get more information, you'll be much more efficient. Another example is a emergency room patient, a head injury, you're comatose. You don't bring, you can't talk to the doctor. What's the history? Well, the history is the EMT coming in and saying, we have a closed head injury, maybe a few other details. That's the history. So I just wanted to emphasize that the concept of history is a little bit broader than just simply talking to the patient, although that's obviously the core element. We have a lot to go, Gil, so I don't know.
No, I know. I'm glad we have a very...
but this is great. These are great questions.
For those of you who are listening, again, this is a sliver. I just want to say this is a slice of a much larger pie that Dr. Gurel offers in the Mini-MD program. And that for those of you who attend the full Mini-MD program, who are not medical professionals, in coordination with AdaptTrack, you can offer then CME accreditation to physicians in an area of specialty that you're training them connected to your company's efforts. And perhaps at the end, Levi Shapiro or Dr. Gurel will offer more background. And again, for those of you who are participating, you can attend at discount the Mini-MD program. At the end of this program, Dr. Gurel will post a slide with a program discount. You'll have till January 4th in order to register. It is extraordinary, and physicians who attend the Mini-MD program and this program can receive CME accreditation. Dr. Gurel, back to you.
Thanks very much, Gil. So the premise of this is to go through the top 10 chief complaints as well as the top 10 mortality. I suspect, Gil, if that's okay with you, I'll do maybe the top 5 of each. I mean, I'll obviously list them and talk about them, but we are approaching the time. So the top 10 chief complaints, what are the most common conditions in primary care? Of course, the chief complaint that I mentioned is very specific to certain circumstances. The top chief complaint in emergency room presentations, chest pain, for example. In primary care, it will be cough, as we will see. For the obstetrician, it might, for the gynecologist, it might be something else, and for the orthopedic surgeon. So it depends on the context. And of course, it depends on geography. Different geographies have different cultures, different epidemiology. So just summarizing here, this was a study that reviewed a lot of reasons for visits, and there were clinician-reported reasons for visits, and of course, patient-reported chief complaints. We're going to focus on these patient-reported chief complaints, and some of the key takeaways that were interesting was that there were differences actually in the reasons for visits between clinicians and patients, and there were also differences between developed and developing countries, which we're not going to go into here. So what are the top 10 chief complaints? Cough, back pain, abdominal, sore throat, skin rash, fever, headache, leg symptoms, respiratory unspecified, and fatigue. For the purpose of time, I will stick to the top 10, if that's okay with you, Gil and Levi. So let's start with cough, and I'm going to take snippets from these different sections of the mini-MD of embryology, anatomy, and pulmonology. So one of the most important concepts in diagnosis, the central tenet of medical diagnosis, in fact, is first to make an anatomic diagnosis, which is a location-based diagnosis, and then an etiologic diagnosis, which is a cause-based diagnosis. Everything in medicine, the symptoms that we described, the signs that we talked about from the physical, objective signs, the laboratory abnormalities, X-ray findings, has an anatomic differential diagnosis. In other words, if we have a symptom like a cough, there's going to be an anatomy associated with that. So what's the anatomic differential diagnosis of cough? Well, we can split it into two, the extrathoracic, outside the thoracic cavity, and intrathoracic. And intrathoracic, of course, is the most obvious anatomic differential diagnosis of cough. And again, this is a simplified version, which is the lung, whether it be the lower airways, the lung parenchyma, the actual substance of the lung, or the lung pleura or surfaces. The second one is the cardiovascular system. How can the heart cause a cough? Well, if you have heart failure and blood backing up into the lungs, that will actually stimulate or irritate the lung tissues to produce a cough. And then you can have extrathoracic regions, which is the head and neck, such as postnasal drip, and the stomach. And particularly what I'm referring to is gastroesophageal reflux, where acid goes up and actually can irritate the bronchus. So if someone's coughing, it may not actually be a lung problem. And a good doctor looks at the whole possible spectrum: lung, heart, head and neck, and stomach, just to simplify. So if we look at cough, cough is down here. It's part of a whole spectrum of other respiratory symptoms. There's a dry versus a wet cough, which is very important. If you remember, COVID was described as a dry cough. And one of the reasons is dry coughs tend to be in the upper respiratory tract, and wet coughs tend to be in the lower respiratory tract, but that's not the only reason. Dry coughs tend to be viral, and wet coughs that produce a sputum tend to be bacterial. And this distinction between upper respiratory tract and lower respiratory tract is extremely important. And when you get infection down in the lungs, a respiratory tract infection, that's called, of course, a pneumonia. So the common cold, for example, is more of an upper respiratory tract. So you get sneezing, you get sore throat, you get congested nasal passages. These tend to have a high transmissibility, particularly with the symptoms, and a low fatality rate. Whereas SARS, the number one, the first one, and then MERS, Middle Eastern Respiratory Virus, also coronaviruses, are more lower respiratory, tend to have a low transmissibility and high fatalities. So for example, SARS-CoV-1 and MERS was fairly not transmissible, only in hospital settings and some other rare settings, but not like Omicron that we're seeing, going wild. So SARS-CoV-2 actually appears to be both upper and lower respiratory. It's a very unusual coronavirus in that respect. So let's talk about back or spinal pain. This is, we talk about the orthopedic section and neurosurgery. Back pain is a very common presentation. And this is Neil Kanowitz, who had written a book on back pain, and he was lamenting how back pain was really painful for the residents. If given the choice of taking weekend call or covering the low back clinic, I would have invariably chosen call. But he did realize that taking care of patients and understanding it was actually quite rewarding to help people. So it's a huge problem. And a few minutes of basic history taking are very critical. And one of the most important things as part of history taking is doctors start to make a decision point. And one of the key decision points in back pain is it non-sciatic or sciatic? Sciatic referring its general concept to the sciatic nerve. So for example, non-sciatic would be more like an arthritis, whereas sciatica, and also neurologic symptom, not just pain, is something related to the nerves emanating from the spinal cord. That's a very rough distinction, non-sciatic or sciatic. Another very important concept for doctors when they're hearing about a symptom are red flags. Red flags are things that mean something really bad. Remember, I talked about the epistemology of action. Doctors act, if it could be a cancer, or it could be paralysis or something like that. Now, of course, those are the very small minority of back pain, but doctors are thinking of these red flags. So there are red flags on the history, symptoms. There are also red flags, for example, on a physical exam. So for example, fever as a cause of infection of that back pain. Unexpected anal sphincter laxity. That's not, a good thing at all, and can represent some very serious conditions requiring surgery. So what are some of those surgeries? One of the main ones is a herniated nucleus pulposus, which is this cushion formed of cartilage between the vertebral bodies. And we have several varieties: spondylosis, we have a herniated disc, and we have disc degeneration. These are fundamentally degenerative processes. And this is the herniated disc pressing on the nerve. That's why I said sciatic versus non-sciatic. And that's producing those symptoms that can be relieved with various types of surgery. And there's laminotomy, laminectomy, and spinal fusion, which are in increasing invasiveness. So for example, laminotomy is just taking the surface off the back of the spine and opening it up and making a decompression, as they call it. Small here, laminectomy is actually to pull out those back portion of the spine. So you open up this spinal canal. And spinal fusion is for more serious conditions. And so the indications: degenerative disease, acute oncologic conditions, and then for the spinal fusions, some of these more serious conditions. So another interesting concept is that of rehabilitation medicine as it relates to the 4 pillars of medicine. You may not find this in textbooks, but this is kind of how I framed it. If we're treating patients, there are 4 ways we can treat patients. We can give them medicine. We can do surgery, hence the physicians and surgeons side of things. We can also do talk therapy. All doctors do that. And you might say, well, what does that mean? Well, of course, for psychiatry, that's very relevant. And I put talk therapy in quotes, not to dismiss it, but to point out that it has many manifestations, such as cognitive behavioral therapy, psychodynamic therapy, group therapy, etc. There are many different flavors of talk therapy. And then the 4th one is physical medicine. And physical medicine is actually a specialty that specializes in these orthopedic conditions, primarily using physical means, movements, exercises, etc., and has various subspecialties. So these are the 4 pillars of medicine. So we can have a disease like atherosclerosis. You take medicine, statins for that, but you can also get surgery if it's serious enough. We have cancer, for example. Early cancer, you might have it removed by surgery. Very late cancer, you might take chemotherapy, which is medicine. You might need to see psychiatrists too for some of the other aspects related to these elements. So it's not like either or, but this is how we approach the treatment. Now, I was referencing this trial, what patients want, surgery versus conservative therapy. This was a fairly famous study. It was a while ago, the SPORT trial. The SPORT trial said there was not a statistically significant difference in favor of discectomy, the surgery, compared with the conservative therapy, which is the physical rehabilitation. So this trial was considered a study, it appeared in the New York Times, etc. But it actually showed something interesting. They allowed the patients to cross over, and that was one of the reasons why the results were inconclusive. And these are the results, so they look almost similar. But because of the crossover, that suggested that patients have a lot of opinions, if you will. You know, some people are okay with surgery. They want to get it over with, and they may have a lifestyle or pain tolerance that is more appropriate for that. Or some people say, well, I'm going to go to physical therapy twice a week, and I'm going to deal with that chronic condition that way. So let's go to abdominal pain. Again, just a sampling from anatomy, the introduction to medicine and surgery. There are different routes to diagnosis. So we have 3 different routes to diagnosis. We can do a positive diagnosis, a confirmatory diagnosis. So that's a specific, that's for example, pathognomonic sign or a blood test. Most diseases are actually diagnosed in this way, maybe not one blood test, but for example, with SARS-CoV-2, the gold standard is a positive PCR for confirmatory diagnosis. Bear in mind that being positive a test does not necessarily mean having the disease. So HIV positive is different than AIDS. There's often a big overlap, but the AIDS is the disease, HIV positive is the virus status. And then there's negative diagnosis to rule out disease. So especially in emergency medicine, it's important not necessarily to say, oh, here's your diagnosis, but oh, you don't have this. You don't have appendicitis. You just have some gastroenteritis or something. So you rule out, and these are typically diseases to rule out. Those that are life-threatening or serious or progress very rapidly. So these abdominal pain is very important. And then there's a very interesting concept of diagnosis of exclusion. Diagnosis of exclusion is kind of the leftover category after you excluded everything else. You may be surprised to know that Alzheimer's disease, generally speaking, is a diagnosis of exclusion. If you see somebody with dementia, you can't just say they have Alzheimer's. Even with a good history, you have to rule out other conditions. Now, of course, you can positively, in other words, confirmatory diagnose Alzheimer's, and that's done by a biopsy. But millions of people have Alzheimer's, and very few of them get brain biopsies for the obvious reasons. So let's go to acute abdomen. This is the famous book by Zachary Cope, Early Diagnosis of the Acute Abdomen, that medical students read. It is of the utmost importance to diagnose early. The majority of severe abdominal pains in patients who have previously been well, again, history, that last as long as 6 hours, again, history, are caused by conditions of surgical import, meaning we need to go in there. Now, this diagnosed early is very interesting because a lot of people say, well, technology is going to cure everything. We're just going to get a CT scan. It's going to pick up that appendicitis all the time. Well, you know, if you have to diagnose early and a CT scan is not available or it's delayed, it takes time. And of course, there's X-ray exposure, whatnot. The physical exam, though that's primitive in the sense of technology, is actually the most powerful way to quickly, immediately diagnose. In fact, that's especially true for the neurological exam, which we're not going to talk about today. So abdominal pain, there are 3 types of pain. There's visceral pain, which is the inner organs. And in the mini MD, I talk about the neurobiology of that. There's parietal pain, which is more related to the surface of the body. That's the sharp pain. So that's one reason why doctors will ask, do you have a dull pain or a sharp pain? They're very different patterns. And then there's also what's called referred pain. Referred pain means a pain that's due to an organ, but away from. So you can sometimes have kidney pain that's down in the groin or liver pain that's up near the shoulder. So as I mentioned, ruling out a diagnosis for abdominal pain is very important. So we need to rule out an aortic aneurysm, aortic dissection, perforated bowel, mesenteric ischemia, volvulus, torsion of structures. Now, you might say, well, I'm going to do a whole bunch of MRIs and CTs and rule these out. That's not the way it works. You can, a good doctor, by taking a comprehensive history, maybe AI enabled, bringing all the information in age, family history, exposures, whatever it may be, bringing that in can rule out this diagnosis on the basis of a history. It may be necessary, of course, to proceed to some other studies. So we have basically between self-limiting, which are essentially localized inflammation, and life-threatening, which means some sort of a physical process. So inflammation is not good, but it doesn't generally kill people. But when that inflammation gets to some physical process like a rupture, ischemia, an ulcer, then it can be life-threatening. Pancreatitis is interesting. It's not a physical process, but the inflammation can be so severe that it can cause basically organ failure. And so that's in the life-threatening category. So let's look at appendicitis. It's the small appendage on the large intestine. We get the symptom progression from visceral. It's in the intestine. Then as it gets out into the peritoneal cavity, it goes to parietal pain. So dull pain migrates to sharp pain, that pattern, again, by history. And then you want to avoid, obviously, a perforated appendix. And there's some signs on physical exam that the doctor can quickly see, as opposed to going to the CT scan and just being a technician, if you will, ordering tests, can quickly ascertain that. So what is the decision to cut or not to cut? One of the most important things a surgeon has to decide. Well, severe unrelenting pain, that's based on the history. Peritonitis comes from the physical exam that I described. Unstable hemodynamically, that's from monitoring. And x-rays can be for various other physical processes that I mentioned. So a good surgeon must feel for their patients, but never let the sympathy disturb their judgment or treatment. There's an interesting concept. It's kind of evolving, but with abdominal pain, you don't want to give too much morphine and knock people out, and their pain is gone because you mask those symptoms and you can't quickly get physical exam. So you don't want the patient to be painful necessarily, but in order to do the right thing, we have to have the means at hand to make that judgment and treatment. So I'm going to go quickly to pharyngitis or sore throat. So the common cold, which is a coronavirus, by the way, is about 50%, and this is in the pediatric section. So we have viral, bacterial, and fungal, and we can differentiate the viral that has this redness and the tonsillar erythema. The bacterial has a different pattern, which you have little bleeding, if you will, internal bleeding called petechiae, exudative, that's that the bacteria produce substances, and then the fungal has this plaques on the surface of the tongue. And then I'll finish with skin rash. Again, this is pathology and surgical specialties. A lot of immunologic reactions. There are 4 types. There's type 1, type 2, type 3, and type 4. I'm going very quickly, of course, but the point is that there are immediate and delayed immune reactions. Immediate ones are over a course of minutes, and these are some of the things of anaphylaxis, you know, from the anaphylaxis from the vaccine reaction. They ask you to wait 15 minutes after, and then they're delayed. It's related to cell-mediated type 4, such as contact dermatitis. One of the key aspects to dermatology, it's like an art form, is how to describe lesions. And so it's very confusing, red, itchy, etc. Well, we can describe lesions primarily, whether they're flat or elevated, or secondarily with loss or gain of material. Those 2 dimensions, primary and secondary. In addition to lesion type, there's a configuration, distribution, texture, and color. So this is the framework that all dermatologists use to basically, like an artist, describe the lesions. And the history is very fundamental. So contact dermatitis is going to be a flat to elevated papules. Psoriasis is going to be an elevated plaque with some scaling, gain of material. And atopic dermatitis has a wide variety of visual signs that also relate to the fact by history it's very itchy and scratchy. So you have contact dermatitis and atopic dermatitis. And atopic dermatitis is typically more genetically related. Contact is with a specific allergen, so it's sometimes called irritant or allergic dermatitis. And these are both called eczema. So in terms of the immunologic reactions, you can tell by the history. Did you get it right away when you get stress or something like that? That would be an atopic or immediate dermatitis. And then contact dermatitis. So this is just a very clear distinction between the 2 that doctors make. So we have fever, headache, leg symptoms, respiratory, and fatigue. These are all very fascinating, but I'd like to get to the next section and entertain a few questions, if that's okay.
Absolutely. Many of our questions deal actually, Dr. Gurel, with issues of behavioral health. You know, how do physicians really inspire their patients to take charge of self-care, preventive care? Obviously, you've dealt extensively in a brief period of time with the expertise of the physician. The other aspect is the physician as authoritative voice and motivator of patient care. So that's a challenge, I think, that the medical system in most developing nations face, which is the doctor sort of saying, hey, you're trending toward pre-diabetes, you're pre-diabetic, you're trending toward diabetes, you have some blood pressure, you need to be adherent to your medication. What are some of your words of wisdom for people who are non-medical professionals to sort of consider what they're doing in terms of how digital health or health information augments the voice of the physician?
Yes, so remember I said the 4 pillars of, thank you for that, Gail, and to the participants asking those questions and related. Remember I talked about the 4 pillars of the treatment pillars of medicine: surgery, quote unquote, talk therapy, and physical medicine rehab. And the talk therapy is not just the purview of the psychiatrist. Every good doctor, we talk about bedside manner, and that's just one particular way of looking at it. But being able to convince the patient, Gail, you're a master, in public relations and marketing and Fin Partners, it's kind of a marketing job. You have to be really good at convincing the patient, as you described, to, in the full sense of marketing, not just promotion and whatnot, but in the sense of explaining and convincing. Now, when I said that slide about the epistemology of action, I was kind of referencing that, because if a lot of people are not easily motivated, except on January 1st, I want to be healthy, and they exercise and whatnot. And that's good. I think that's very obviously admirable. But the reality is, as I mentioned, just human nature. I talked about the news cycle focusing on negativity. The reality is human beings are motivated often more by fear. And that's maybe not the nicest way to frame it, but it's just the reality. And so one of the jobs of a doctor is to identify those bad conditions that come up, and to judiciously and properly communicate that. If you have diabetes, maybe you will live for a long time, but in 10 years you may go blind, or you may not see your children or whatever. I mean,
And Dr. Gurel,
yeah,
that's a great example of, I think, a wet
cough.
cough.
Yes, exactly. I was about to say it's a pretty wet cough. So again, I wouldn't want to make a diagnosis without even
Who's been
seeing it.
muted? I want to just say that luckily I've regained control of the host function. So,
good.
But that was a cough at the wrong time. They needed to cough when you were talking about
Yeah, exactly.
as a diagnostic.
So back to my point. So finding those red flags and emphasizing that and communicating that is very important. But I will actually go back even deeper. Doctors have limited time, and they can't, be in the job of educating patients about everything. I do believe, and one reason why I'm passionate about the mini MD and hope ultimately, actually, one of the future projects is to make this as part of a general education process, is to improve general education, not just for healthcare leaders and professionals like you, but everybody in some ways. And obviously, we in junior high school and high school, we get some health ed. But as I mentioned at the beginning, if we had better health education, we will be able to take better care of ourselves, be able to react to pandemics and other issues much better. And I think there is a fundamental missing component. And in fact, I believe this is the elephant in the room about digital healthcare. We talk about preventative medicine, consumer-centric healthcare, patient-directed healthcare, personalized medicine, all these great sounding words, and throw a lot of gadgets at that. But if the patient actually doesn't have a fundamental understanding of basic health processes, and it's just a black box, I see those things as being quite limited. Not useless.
Very important comment from one of our participants today, Nahama, who talks about the data show that fear may not be a lasting motivator. And I often find that if we look at smoking cessation, when a child goes to a parent and says, "Daddy, I'm frightened that you're smoking, and I love you. I want you to be around." The lovingness is sometimes the desire to do because we love can be a stronger or more enduring motivator. And as a physician, as an expert, as an educator, what are your thoughts about the balance between love and fear as a driver of behavior?
That's fascinating, doing mini MD and then talking about the balance between love and fear. We are definitely having a wide range of conversation. Thanks, Gil. Always a pleasure. And yes, I mean, these are very deep issues, obviously related to, how the human mind works, cognition, communication, many factors. And I'll answer that question with the following. First of all, I will say, I think obviously love and the positive side is more enduring, and the negative side can really incite to action. And this will relate to neurobiology of the amygdala and things like that, how we react to the short-term stress, long-term stress, and whatnot. So Dr. Meklon asked the question, chronic conditions like hypertension, diabetes can be cured with lifestyle modifications. I don't know if you saw, but I posted on LinkedIn something that I posted last October, 2020, about COVID being endemic disease. And I said, one of the implications is that if you have obesity, severe obesity, and significant cardiovascular conditions such as hypertension, typically those are kind of like conditions that in 10 years you might, die, or longer, 20 years, whatever. So the motivation is a little bit diluted to take care of that. They are not considered acute conditions. So by the system, as well as the individual, in terms of chronic care treatment and whatnot, we consider these chronic. And so we have big structural societal issues with, preventative medicine because it's so far off. It's just human nature. We don't prepare for a pandemic until a pandemic happens, that sort of thing. But the interesting thing about the COVID is that those pre-existing conditions, not all pre-existing, but specifically those and some related, become acute. In other words, if you have hypertension or obesity, you're not going to die in 2 weeks because of that. I mean, hypertension, sometimes uncontrolled, whatever. But in general, this is not going to be an acute condition. But if you get COVID, you could die in 2 weeks. In other words, the prospect of COVID being out there converts a lot of these chronic conditions into acute possibilities or acute menace. And I think that might change the motivation process. And I agree with you that obviously the positive is more sustaining, but we've had so much problems with treating chronic disease related to these motivational aspects, which are not just individual, but societal, that maybe COVID, by converting these into acute menaces, could give extra incentive, not
I
just
was
to
going to say,
individuals,
this is
but to
probably
society.
one of the biggest public health takeaways from this brief conversation with you
Oh, it's very
today.
important.
Very important is that often what we thought were chronic conditions, which is
Become acute, exactly.
right, become acute suddenly. And you mentioned with COVID, how do you prepare for the next pandemic? Well, some things you can't prepare for because we don't know the construct of the virus itself. But we do know, according to your wise words, that actually we as biological beings or test tubes, as it were, that we can better prepare our bodies to deal with the next wave of pandemics.
That's right.
By being
Totally
in
agree with
better
that.
condition. And I think
That's
that,
right.
I think that there have been countless people who have heard this today, will hear these words on recording. And, I think that you have contributed to saving thousands, maybe to tens of thousands or hundreds of thousands of lives by people taking your wise words into action. We have a few moments left, and before you close, and I hope that you can stay a little longer, Dr. Gurel, but I just want to say that Dr. Gurel is gracious. He invites your following him on LinkedIn. He invites you following him on Twitter, which is very good. I think, Dr. Gurel, we have another section to cover. Is that correct?
Yes, so I can go until the hour. I know many people have
Would you
scheduled 90
please,
minutes.
would you please,
I'll be
because
okay with that.
we are
Yeah.
recording this, and therefore people have the advantage of hearing that section in words. So I
Sure.
thank you very much for that. And I just want to say again, please follow Dr. Gurel on Twitter and LinkedIn. Thank you. We're going to cover another section. I'm very appreciative to our very special guest. I want to remind people that if you're a physician, by participating in the full program, you can receive CME credit. And I also want to recommend to people who are non-physicians, by participating in the Mini MD program, which you have until January 4th to get the early bird discount to the program, you will be certified to provide CME to physicians through AdaptTrack. And Levy maybe will mention more of that. So we're going to continue to the top of the hour. Dr. Gurel, thank you so much for your graciousness in staying with us a bit longer. And I invite our audience to stay with us. And obviously we're now recording this, so it will be available for you to view again. Please continue.
Yeah, thank you. So I do think it's a very important public health message, and I'm so glad, Gil, that you highlighted that. I'll just contrast. The flu obviously kills people at a lower rate than COVID, but it doesn't have this connection to these pre-existing conditions. It's mostly related to general age and immune status. So the very young and the very old have a risk of dying of flu. But COVID has a broader age range, and it's related to these conditions. So the biology, which I go over in the mini MD, is very different. The target for flu are these type 1 surface cells on the lung, and the target for COVID is these type 2 cells in the lung and other cells that express ACE2 protein, ACE2, many of you have heard about, of course, is a key linchpin in the cardiovascular system in the transition from inflammation to repair. It's a key weak point in the body, particularly in the context of some of these ongoing inflammatory conditions. I'm simplifying very complex issues. So, you know, in terms of other infectious diseases, this unusual confluence of chronic conditions becoming acute, as you pointed out, is uniquely seen with COVID. So we're going to continue a little bit. You were mentioning about talk therapy, and I'll just finish up with fatigue because I'm going to mention a little bit about psychiatry. In psychiatry, DSM-4, which is replaced now by DSM-5, and I'll explain that briefly. It's interesting. The psychiatrist also embodies this holistic view of medicine. And one of the ways is to express this axis of diseases. So the axis 1 is actual psychiatric disorder, axis 2 is personality disorders and mental retardation, axis 3 is general medical disorders, not just psychiatric. Axis 4 is the psychosocial dimension. This relates to the whole background that's related to convincing. That's why I'm talking about it, Gail, here. And axis 5 is a global assessment of functioning. So, and the DSM-5 is released, and I'm not going to go into the details of the controversies related to that, which is very important, but we don't have time for that. So the multi-axial assessment, as I mentioned, is axis 1 is the actual psychiatric disorders, personality disorders, axis 2, axis 3 is general medical, axis 4 is psychosocial, and axis 5 is the general functioning. So a very important concept in psychiatry is the decision point, just like in back pain, sciatic or non-sciatic, between organic etiologies and not organic etiologies. What are organic etiologies? These are ones like the endocrine system. You might be depressed because you're hypothyroid. You might have depression because you have a pancreatic cancer. 25% of pancreatic cancer manifests as depression. Infection can make you tired, and so forth. So the organic is a medical or axis 3 diagnosis. And no organic doesn't mean that it's fake. It just means it's not related to some of these medical conditions. And that's axis 3. And axis 1 are the psychogenic organic. And that relates to the whole landscape of psychiatric disorders, which can be split into anxiety, mood, and thought. And again, it's very important to think organic or substance abuse. And these landscape is related to neurotransmitters with serotonin on the mood side, norepinephrine, which is related to adrenaline on the anxiety side, and dopamine on the psychosis side. So now let's talk about top 10 causes of mortality. And just like last time, Gail, I'm going to do just the top 5. Obviously, Gail had posted something from Medical Life about how mortality is defined in very strange ways, or I shouldn't say, is not necessarily purely logical ways. And there's controversies, something COVID is something not. If you die of if you die of organ failure, secondary to COVID, what is the primary? There's a lot of, how should I say, blurry zones in how we categorize death. In addition, it varies by year. Last year, COVID was number 3 in the top 10 list. So it changes by time, obviously, and also by geography and income status. So this is the top 10 causes of death in high-income countries. And an interesting thing is, as I mentioned, the cause of death can be very easily misinterpreted. There was a study in the British Medical Journal that said the 3rd highest cause of death was medical errors. That's a little bit controversial, but I think it's still significant. So that being said, I'm going to concentrate on this list. And then, by the way, there was excess deaths in 2020. This is for 2019 from the WHO. And these are the top 10 causes of mortality according to the WHO in 2019. Ischemic heart disease, Alzheimer's, stroke, lung cancers, COPD, lower respiratory infections, colon, rectal cancers, kidney, hypertensive heart disease, and diabetes. So I'll just do a few of these in the next few minutes, and then we'll stop at the hour. So ischemic heart disease. We're going to cover some sections from cardiology. One important distinction is that between cardiac arrest and heart attack. They're often easily confused. One way to think about this is to actually understand that for the purposes of disease, there are three parts of the heart. There's the electrical system that coordinates the contraction of the heart. There's the circulatory system that sends blood to the muscles of the heart, and there's the muscle system. So cardiac arrest is essentially an electrical problem. It can lead to, heart failure and so forth, but it's fundamentally an electrical problem. Whereas heart attack is fundamentally a circulation problem, namely a blocked artery, and that can also affect the muscle, of course. So these different diseases manifest these different parts of the heart. So we're going to focus, of course, on ischemic heart disease, and that's related to atherosclerosis. Atherosclerosis is developing a plaque that develops over time in the arteries related to cholesterol. You have various stages from intracellular to extracellular accumulation. That becomes hardened into a fibroatheroma, and then what we call vulnerable plaque or complicated lesion that can have a thrombosis and a sudden blood clot. Now, how does this occur? Well, in addition to high cholesterol, there are aspects of the geometry of the blood vessels that relate to the way blood flows. And we have two types of flow. We can have laminar flow, which is very smooth, or we can have turbulent flow. And it's in these regions of turbulent flow that we develop these plaques. So that's why a medical disease that's generalized throughout the body can have very specific, localized, or surgical consequences. In other words, it's a generalized disease with segmental manifestation. So we review ischemic heart disease. Again, normal coronary artery becomes an uncomplicated atheroma. We get a fixed lesion that's pain with exercise, and then we have an unstable plaque, which is pain at rest. So this is an important clinical distinction. And ultimately, that can lead to a blocked artery. And these are progression of blockage. But the key thing is, the trigger point, if you will, is how can we tell if the heart muscle is dead? And we call that necrosis. And so we have various acute coronary syndromes, and I'm going to go through this quickly, but the EKG is a very important component of that. And this ST elevation, and in the mini MD, I go through the EKG, so this is all very easy for those who participate. And the ST elevation is indicative of muscle cell damage, and that's corroborated with biomarker testing to give the final diagnosis. So here's a clinical case. This is on May 7th, 2018. And this is myself, and I'm being wheeled to the cath lab. And I had chest pain, and I had chest pain for a long time, even since adolescence. So maybe this was an old problem. I've had high cholesterol, but this was the first time it went to my jaw. And I knew immediately this was different. And so I called an ambulance. This was back in Korea. And in the ambulance, they did an EKG. I asked to see the EKG. I saw the ST elevation. I knew that I would need an intervention. So I told the ambulance driver, you should go to this hospital, because I knew they would have the interventions as opposed to just the first ER. They said, okay. And we went to that hospital, and I was being taken and operated. I got 2 stents within 2 hours of symptoms. And less than 1 year later, I finished the marathon in Almaty. And that's, basic medical knowledge, basic history. And I just wanted to share that as a case. Let's go to Alzheimer's disease. First of all, Alzheimer's disease falls into a category of degenerative diseases in the brain. And that can be of cognitive or movement related. And the DSM-5, as I mentioned, which is related to psychiatric and neurologic conditions, memory impairment, and one or more of the following. And we can have amnestic, which means related to memory, and non-amnestic, other symptoms. And it's very important. This is a key point. The cognitive deficits result in a functional impairment. So Alzheimer's is not necessarily psychiatric diagnosis in the sense of mood, psychosis, or anxiety, but in psychiatry, and again, this is looking at the big picture, a disorder is only a disorder if it actually affects your functioning. So for example, obsessive compulsive disorder. For a surgeon, a neurosurgeon, for example, a certain level of obsessive and compulsiveness is very appropriate. That level of OCD might be inappropriate in another setting. So this is all related. These diagnoses are related to the functional impairment or not impairment. and it's not due to other medical or psychiatric conditions. Again, diagnosis of exclusion concept. So these two important principles of psychiatric diagnosis, impairment and it's a diagnosis of exclusion. So let's look at the etiologic diagnosis of dementia, not the anatomic diagnosis, but etiologic. So if you see someone that has dementia, you don't immediately say, well, they have Alzheimer's. Those are primary dementias. There's also secondary dementias, which is very important. And this is a very important concept in medicine. So these are a rare, not rare, but less frequent cause, etiologic cause of dementia. Things like taking certain drugs or endocrine disorders or a cancer, brain tumor, a subdural hematoma, some blood in the pressing on the brain. These can cause dementias. And why is it important to make this distinction? Because if you fix these things, take out the drug, treat the endocrine disorder, take out the tumor, drain the hematoma, you immediately reverse, in most cases, the dementia. It's not like, oh, they had dementia, that's it. Let's send them off to the old person's home type of thing. So you have to consider the secondary dementias. And then you go to the primary. Then you rule out these others. And Alzheimer's is even though it's the majority, is technically a diagnosis of exclusion, although you can rule it in, of course, with a biopsy, which is rarely done. So Alzheimer's is accumulation of proteins that cause damage. These are alpha beta proteins, beta amyloid, and then those are extracellular, and then you have disease progression, you have intracellular tau proteins in high levels. Those proteins, et cetera, cause damage to the nerve cells and ultimately degeneration. Let's talk a little bit about stroke. There are two types of stroke: ischemic stroke, which is caused by a blood clot or some sort of clot blockage, or when the blood vessel bursts, and that's a hemorrhagic stroke. And the consequence for both of those is the brain cells die because of a lack of oxygen. And it's, of course, a very big deal. And you learn about the fast presentation, face drooping, arm weakness, speech difficulty that are called right away. And so this is a very powerful example of Congressman Ron Paul. Whoops.
Former Texas Congressman and former presidential candidate Ron Paul was hospitalized today after he suffered a medical condition and started slurring his words during a live stream.
Former Congressman Ron Paul suffers a major medical incident, and it was broadcast live. The 85-year-old physician was taking questions on his live streaming YouTube channel when he started slurring speech and talking gibberish. His guest was in complete shock.
Dr. Paul?
We have just learned that former Congressman Dr. Ron Paul, 85 years old, has been hospitalized in Texas.
Dr. Andrew Rogove of South Shore University Hospital in New York said the incident looks like the signs of a stroke.
With the difficulty speaking and the facial droop, it's very concerning for a stroke.
Today, Paul seemed to be feeling better, posting a thumbs-up photo from his hospital room. His son, Senator Rand Paul of Kentucky, tweeted, "Thank God Dad is doing well."
So that was a very powerful example. You can see, now you might say, well, let's treat him right away. But the most important thing is to determine whether it's ischemic versus hemorrhagic. Put it in very rough terms, ischemic means too little blood. Again, I'm simplifying. And hemorrhagic means too much blood there. So the treatment approach is actually the opposite. So even though the symptomatology is very similar, I have no way of telling if it's hemorrhagic or ischemic from what is, is immediate presentation, Congressman Paul's. But if I knew, for example, he had a history of hypertension, I might go more for hemorrhagic. But the definitive way to confirm that is with a CT scan. So one of the first steps in a stroke is to do a CT scan. Is it ischemic, which you'll see this pattern, less white, means less blood, or you see hemorrhagic, you'll see this pattern, where you see the blood as outlined. So the initial management of stroke is to stabilize and then distinguish between hemorrhagic and ischemic, which means the ABCs, airway, breathing, circulation. We go that in trauma. Gil knows this very well as a former EMT. Quick neurological assessment. You put in a CT IV for the CT angiogram labs, and call for the CT scan. So let's finish actually maybe with one or two more of these. We're going to talk about lung cancer, and in that we'll cover aspects of tumors, some pathology, and pulmonology. So pathology, there are several methods of pathologic study. An autopsy looks at organ structure, obviously post-mortem. A biopsy looks at tissue structure. Cytology looks at cell morphology. So we're going into increasing or detail, more microscopic, and imaging is typically not considered in the pathology, but there's a fusion between some aspects of radiology or imaging and pathology. So let's look at this in a little more detail. This is an example of meningitis. I told you that infection over the surface of the brain on autopsy. Biopsy, this is an example of a small cell carcinoma of the lung. We take a piece of the tissue. Cytology is we don't take the tissue, but we siphon off cells. So we're not looking at the tissue structure, we're just looking at the cells. And here's an example of imaging. So surgical diagnosis, especially in cancer, since we're talking about lung cancer, there's a phrase, it's not very pleasant, but no meat, no treat. If you don't have tissue, you cannot decide what it is, you can't treat it. So surgical diagnosis is very important for the actual diagnosis. It's also important for the staging. So if you tell someone, you know, I have breast cancer, that's a meaningless statement to a doctor. Well, it's not meaningless, but it's pretty vague. But if you have stage 1 breast cancer versus stage 4 breast cancer, that's a lot more meaning. So the stage is extremely important because it's related to the treatment, it's related to the prognosis, it's related to everything. So there are various biopsy methods with different benefits and risks and so forth. So let's talk about staging and grading. So this is an example of colon cancer. I told you about stage 1, 2, 3, and 4. Roughly speaking, more deeper and invasive tumors. There's a systematic framework to this. So the staging is the anatomic distribution of the tumor, typically done either radiologic diagnosis or surgical. And then there's the grading. Grading is looking at the individual cells and seeing how aggressive they look by various criteria. So this is the extent of the tumor, anatomic. This is the biology of the tumor, histologic. So for some cancers, staging is more important, particularly lung cancer. For others, grading is more important. Generally, both are important in the clinical prognosis and treatment decisions. As I mentioned, diagnosis is relatively meaningless without a stage and a grade. So lung cancer, for example, earlier stage is better survival. Most stage 1 tumors are curable. Most stage 4 tumors are inoperable. So you have a progression from surgical to medical. So earlier stage is more surgical, and intermediate stage, you might have some mix of surgery and medical. So I will skip over to diabetes mellitus. So this is pulmonology. We go through some of, here, this is a interesting slide. If you have chronic obstructive disease, your lung volumes are bigger, and that's called the obstructive versus restrictive diseases. And you can actually tell that on physical exam. By physical exam, I mean observation. This is a barrel chest, which is very pathognomonic of chronic obstructive pulmonary disease. Over time, the chest actually gets bigger as these lung volumes are bigger. And there are various obstructive diseases. And let's keep going. Back to pneumonia, a little bit about COVID-19. Oh yeah, this is actually a very interesting point. So we talked about diagnosis. And if you remember in the early days of the pandemic, in China, they noted a very huge peak. And that's because they were running out of tests and they decided to use CT scan as a diagnosis of COVID. And these are all the cases added by the CT scan. And so this was a laboratory diagnosis. This was a radiologic diagnosis. And people were saying, okay, well, that means you're just messing with the numbers. This is fake science, all this kind of stuff. People didn't really understand how medicine works, but that's, what happens. And this is actually fairly typical. You can make a laboratory diagnosis, you make a clinical diagnosis. I even have anecdotes where you can, diagnose clinically COVID. Somebody definitely has COVID without taking a test. It's based on the history. And so this is one example of that. respiratory failure, colorectal cancer, again, the staging, et cetera, is important. Metastases, acute kidney injury. And then we're going to finish with diabetes, hypertension. Oh, I'll spend a little time on this. It's actually very important. Remember, I was talking about primary versus secondary dementia. This is a very critical thing with hypertension. So people say, well, you diagnose hypertension with a blood pressure cuff and get the hypertension, right? Well, first order of business, again, there's these decision points I emphasized, medical logic. Is it primary or essential hypertension or secondary? Secondary is rare, but it's important to rule out a directly treatable condition. And the secondary hypertension are things like stress, atherosclerosis, renal artery disease, diabetes, etc., pheochromocytomas type of tumor, etc. So these are things that can be addressed, and you don't just give antihypertensives for the rest of the patient's life. You have to rule these out. So this is a case of a participant in the mini-MD, young professional. This was about a year and a half ago. 3 years prior, were diagnosed with hypertension. They were on antihypertensive medicine. They saw this framework of primary versus secondary. So after taking the mini-MD, they decided to look deeper into secondary. There were some clinical clues, historical clues. They had some mild edema, swelling, difficult to lose weight gain. This younger person, previously attributed to stress. Ultimately, imaging showed a small aldosterone secreting adrenal tumor. They were switched to the correct medication. They got the surgery to remove what turned out they're often benign. But the point is, if that wasn't done, they would have been on antihypertensive and struggling to keep up with this for maybe the rest of their life. So complications of hypertension, heart, etc. So we're going to finish with diabetes mellitus. I like to finish with this one, not just because it's number 10, but diabetes is so widespread. In fact, it covers a lot of areas. So these are different areas: anatomy, internal medicine, introduction to medicine, systems physiology, general physiology. So an important concept is that between the fed state and the fasting state. As everyone knows, diabetes mellitus is about insulin. The insulin controls blood sugar. And that blood sugar, or glucose, goes from the gut to the brain, and constant levels have to be maintained sending to the brain. And in the fed state, when you have eating lots of glucose, this is going to the brain. It's also being taken up by the liver. And in the fasting state, we need to still create a steady level for the brain up here. So we cut back on the liver absorption. In fact, the liver can give up glucose. And so this constant level of glucose is actually a varying level of insulin, high insulin here and low insulin in the fasting state. So this is what we call principles of homeostasis. Homeostasis means things are constant. To be actually precise, this is not entirely correct. Even though these negative feedback systems are important for maintaining this homeostasis, these constant levels, such as in the endocrine system, rheostasis is a more accurate model. Rheostasis is a kind of shifting of states of the body from the fed to the fasting state mediated by that hormone. So another important concept is how the hormone insulin is anatomically distributed in the body. So in the circulation, the pulmonary circulation and systemic circulation, we have a very simple model of the arteries leading to the capillaries to the veins. Again, in the systemic circulation, arteries, capillaries, veins. So you have one intervening capillary network. But in the portal circulation, which is related to the gut and the pancreas, we have the artery coming out of the heart, and we get a capillary network in the gastrointestinal tissues, absorbing glucose, releasing insulin, and then it goes into the veins to the liver for a second capillary network, and then goes back to the heart. So you have two intervening capillary beds. Why is this important? Because in the normal case, the insulin coming from the pancreas is coordinated with the glucose coming from the gut. But if you're a patient with diabetes and you're injecting insulin peripherally, subcutaneously, you don't get that actual anatomic correlation. And I wrote an article about this a few years back. medical versus surgical disease. So there are two types of diabetes, no insulin or cells not responding to insulin, type 1 and type 2 respectively. A very important molecule is hemoglobin A1c. The hemoglobin is a very important molecule in the blood. It transports oxygen from the lungs to the tissues. And if there's a lot of glucose around, it will bind to the hemoglobin and you'll get what's called glycated hemoglobin, hemoglobin A1c. So since the red blood cells are traveling in the body about 90 days, the glycation of the hemoglobin is a measure of your average levels of glucose. So these are good levels, they're relatively low, excellent levels, I should say, good. And then hemoglobin A1c above 9 or so is very bad. So 7, we're getting into this pre-diabetes and we want to be below 7. So this guides how we treat diabetes. By after the diagnosis, we titrate everything to hemoglobin A1c. First, we start with lifestyle management, check the hemoglobin A1c. Then if it's too high, above 7, then we start the first level treatment, recheck, second level treatment, and then intensive treatment. The important principles are clinical monitoring and the graduated intervention. This is a very interesting case study. We were talking about the questions about motivation and how do you motivate patients. As you know, type 1 and some type 2 diabetics require insulin. And this is subcutaneous injection. I told you about the discordance in the anatomy. That's another topic. But about 15 years ago, there was Exubera, which was a Pfizer drug of an inhaled insulin so that people wouldn't have to inject the insulin. And this was a complete flop, $3 billion loss, maybe $6 billion. And the main reason for the flop was one of the reasons why people find insulin injections uncomfortable is not just the pain, which is usually can be overcome, but the social embarrassment. You know, you don't do, I don't have diabetes, but I'm not going to do an injection, you know, right on Zoom call. You know, we keep those things discreet. So, but look at this. This looks like something that college students might do in their dorm room. Looks like what people call a bomb. So this is, you know, socially kind of doesn't work. So what I mean to say is that even though technically this was very sophisticated, the social embeddedness, the motivation of the patient, the social context just did not fit, and it was a complete failure. And we learned this principle: doctors do not treat disease, they treat patients who have disease. So this is related to that question. The greatest mistake in the treatment of diseases, as Plato said, is that there are physicians for the body and physicians for the soul, although the two cannot be separated. And I'll end with the section with the first aphorism from Hippocrates. Life is short, the art is long. People know that. Vita brevis, ars longa. Medical education never ends. The crisis is fleeting. Decisive is important. Pure empiricism is unreliable. Decisions are very significant. The doctor has to make the decision, but this is very important. They have to engage the entire stakeholders, to use a modern term. They have to make the patient, the attendants, and the externals cooperate. And that's not just for doctors, but anyone in healthcare. We have to have an integrated approach. We can't just take a silo, one piece of the pie, and expect to be successful. I'll take a few questions and then finish with a few slides.
Wonderful. And Dr. Gurel, could I ask you if you would be kind enough to summarize, you know, I know that you know this presentation so well. Would you be kind enough to summarize some of the key takeaways? I want to again say to all people who will hear this recording, who are participating right now, this time together was a sliver of a greater, informative, exceptional program titled Mini MD. You can find Mini MD online. You can register for the upcoming session with a discount. Dr. Gurel, I hope you will share the slide, if you don't mind, about the upcoming Mini MD program and the discount for people participating today. And I also invite people to follow Dr. Gurel on Twitter and on LinkedIn. He's very engaged in both social platforms. You can see a lot of the articles that he mentioned during the conversation today on his social feeds. So please do that. And Dr. Gurel, if you'd offer a quick summary and then share a little more about the mini MD program, I would very much appreciate it.
Sure. Thank you very much, Gil. It's very difficult to summarize all of medicine in 30 seconds or 1 minute, let alone 90 minutes, which clearly we had to go a little longer. But I would say there are a few recurring themes. Some of them seem obvious, and that's one reason why in medical education, it takes a long time. We put it in context, we see patients, we make connections, but patient comes first. That's an obvious one. And more specifically, listen to the patient. And all good doctors know that. That's why I started my comments at the beginning thanking patients, not just Gil and Levy and mHealth Israel, the usual introductory comments, but thanking patients because we learn from them. And if we have an open mind and are continually learning, and this is where the continuing education comes in, by the way, we will be better doctors. And the concept of knowing everything and being, perfect and genius or whatever is the first step to actually being the opposite. And of course, even COVID, we know, there's genius doctors and brilliant immunologists and so forth, but we were all learning. And this openness to learning, specifically from the patient, listening to the patient, is a very important principle. That relates to technologies too. If your technology is not really built in subtle or not so subtle ways with that philosophy in mind, it's going to get limited traction. Related to that is the central importance of the history. Now, granted, you may make a medical device that's related to a particular surgical procedure, and that's great, but understanding the embeddedness in the wider medicine is very important, and the central role of the history in that. And AI, to the extent that AI is becoming a key medical technology, intersecting with the history is very important. And the failure of IBM Watson was because it just didn't really engage in that broad way with the history. It was just basically taking some parameters and looking up thousands of articles on the web and trying to figure out some patterns based on limited dimensions ultimately. And then in relation to doing the history, I think that understanding the integrated aspect of healthcare. I talked about psychiatric diagnosis, not so much to emphasize what it takes to be a psychiatrist, but to show that a psychiatrist is thinking, is this a medical condition? And if they don't think, is this a medical condition, and they just go straight to the psychiatric diagnosis, they're not being a good psychiatrist or a good doctor. The same thing with a surgeon. I mean, they need to think of these broader issues and not just a technical thing, what's the blood sugar, what's the blood potassium, et cetera, so that they survive the anesthesia and whatnot, but in a broader sense, even the lifestyle and how it relates. As I mentioned from that clinical trial, neither surgery nor conservative treatment was definitely superior to the other, but patients do make a choice, and it's related to factors that are not just quote unquote medical or technical. So those would be some of the key summary points. Listen to the patient. Patient comes first. Listen to the patient. History is very key, and have a very broad outlook, and ultimately be open to learning.
Thank you for that. By the way, many people who have attended your mini MD program, some amazing colleagues, I want to thank them for putting comments in the chat for that. That's a great endorsement. There are many endorsements for your mini MD program from Johnson & Johnson and Samsung and Fortune 50 companies. Obviously, it's a great opportunity. Some of our colleagues who are on the entrepreneurial side of health innovation have also participated and attest to the value of the program to get into the medical mindset as opposed to the engineering or just inventive mindset. You need to know the mind of the customer or the challenges of the customer in order to invent for the customer. I want to thank you, Dr. Gurel, for that. I also want to thank our colleagues who participated today in this. A special call out, of course, to Levi Shapiro and the mHealth Israel community for making this event possible. Levi has been known for quite some time as the ambassador for health innovation from Israel. He's evolved really into the ambassador for health innovation around the world. So Levi, if you're listening in, and I know you are diligently, our thanks, all of our thanks to you. Dr. Gurel, I notice that you practice what you preach. Obviously, we are grateful that you diagnosed and sustained and saved your own life. We're very appreciative of that as we enter into 2022. We also know that you maintain a very strong regimen of maintaining your own health, of exercise. That big H to the right of your shoulder is not your Harvard undergraduate degree in chemistry. It is because you served on a championship Harvard crew team as coxswain, as the navigator of the shell, which is essential. You can row to your heart's content, but if you're not rowing in the right direction, obviously you will not win a championship as you have. So I think what you've said today is, if you want to be part of the health community, you can row, but you need to have baseline medical knowledge to get to the right point and be a champion in sustaining and saving people's lives. And I want to thank you for making this possible today. This session largely was recorded. I apologize. I was able to gain control as host and mute people midpoint and started to record. So we have most of this. That's why your summary was so vital to us.
Thank you.
Through Levi Shapiro, this recording will be made available. I hope people took notes. Dr. Gurel, would you please put up a slide on how to access the mini MD program? I think many people have been tweeting how interested they are in that. And I want to make sure that people know it is extremely affordable and informative. And I want to make sure people know that you're offering to people participating today a very special discount. Thank you for that.
Well, thanks for Gail for the opportunity to summarize. I think it was great. I love kind of the questions and thinking about things and so forth. So and thanks for the many comments that I saw in the chat room. It's a real pleasure to see that and to have that impact. So I'll just proceed to a few slides here. So the mini MD coming up will be at the end of January, early February, 8 live interactive 3-hour sessions. They will be recorded so participants can have access, exclusive access, it's not open public access, to the recorded lectures specific to their email and the presentations. But it's best, it's a kind of really shared experience. It's that immersion experience. If you can't make all of the sessions, you'll have the recordings, but if you can make most of them, that's great. And I know it's a big, relatively big block of time, but it's relative to taking 4 years of medical school, it's obviously quite minimal. And this is the curriculum, as I mentioned. We've actually touched upon a number of these today. We talk about the language of medicine, but it's not a terminology course. We talk about the logic of medicine. You might have seen these yin-yang symbols, and I use those to describe these dualities. For example, sciatic, non-sciatic pain, primary hypertension, secondary hypertension. That's the logic of medicine. And then the language and logic of medicine combined, inflammation, repair, neoplasia, degenerative disease, all diseases can fall into these 4 categories or some combination. And these are the itises, such as meningitis, laryngitis, pharyngitis. All of these are inflammatory conditions. And then we were talking about COVID and its unusual intersection with certain conditions. There's a link to inflammation. And ACE2 protein has that link. And I don't have time to go over that, but we talk about that in the mini MD. And it's interesting, medical terminology can be confusing. Cellulitis is very different than cellulite. Cellulitis is primarily an inflammatory condition, infection of the skin by bacteria, whereas cellulite, the bane of older age, is a degenerative condition. So very different conditions, very different pathologies, but obviously a similar name. And Plato said they certainly give many strange names to diseases. So I also do the patterns of medicine. There's a actual design to these slides. There's a design to the knowledge, etc. We call that a Gestalt design. I won't go into that. Obviously, it's based on my medical background, but I update this every year. This is me at the Harvard Medical Internal Medicine Review. I go every few years. This is Barry Brenner, one of the top nephrologists in the world. I refer to T.S. Eliot's triangle. Many of you may know this. We have data. Then we have information, knowledge, and then wisdom. My goal is to try to extract some of this wisdom, not so much, my wisdom, but people like leaders like Barry Brenner. I've distilled all this wisdom that I can take from my medical education, of course, subsequent to that. And this is what I try to share in the mini-MD. So that's also, as you saw, there are quotes interspersed throughout. I've a lot of great network with physicians around the world that I've interacted. Many of these are classmates, friends, others who have commented and given feedback on the mini-MD. So as I mentioned, this is the timing, and you can go to the website. The website has all the information. There's some links for the testimonials, etc. You can click here to pre-register. There's a very simple pre-registration form, and then at the bottom there's a referral code. The early bird discount is until December 31st, but for this group, I've extended that to January 4th, and you just enter after your name and affiliation this preview code, and then we just follow up with the registration details from there. So Happy New Year, and even though this is the last slide, we're starting the new year, and shall we start for new tomorrow, and hopefully will improve the healthcare system altogether.
We thank you so very much for spending the last days of 2021 with us. It was a great session. Almost all of the chat comments as you were wrapping up were from your students who've attended the mini-MD program, applauding you, the program. And I know many of these people, and these people are really game changers in our industry today. For them to acknowledge you is really a statement, an affirmation of how you've contributed not only to their well-being and knowledge, toward their wisdom, but obviously toward improving human health overall. Again, thank you so much. Thank you to Levi Shapiro. And
Gil, sorry to interrupt. If you can save the chat, and I'd love to follow up personally, if that's okay. Save the chat once you close off.
Yes.
I don't think anyone puts the private information.
Yes, no one put private information. I'll get some advice. If someone wants to put in the chat how to save a chat, I will certainly do that. Let's see how we
I think when you close, it will open up as a chat. Anyway,
okay. Very good.
It'll be wonderful to connect with all.
And I just want to say, you've been gracious to put your LinkedIn address in the final slide. I've also put it out on the chat. You also are, you welcome people to follow you on Twitter. Your name, Ogan Gurel, is at Ogan Gurel is your Twitter handle. Yes, so I encourage people also to follow Dr. Gurel on Twitter, as well as Levi Shapiro, who could be found as at Lev Shapiro, one word, on Twitter as well. This way you can stay in touch with the mHealth Israel community. Thank you so much for joining us today, everyone. I want to wish everybody a wonderful, wonderful close to a year of health and happiness, of promise and prosperity in 2022. Take care.
Thank you very much. Thanks so much, Gil. Thanks to Lev, and thanks to all the participants, and Happy New Year.